We're fortunate today to have Dr. Cawood come and speak to us. Dr. Cawood is a director of the Pulmonary Vascular Department, which does focus, he and his staff, they just focus on pulmonary hypertension. Many lectures, one time he canceled an appointment because he was lecturing in Nice. Another time he was in Beijing. Dr. Cawood.
Thank you. An introduction which is clearly too generous. So let's go to another study that we're actually doing right now. And this really relates to estrogen. So again, sitting in this room, it's no surprise that this disease is a female predominant disease. And we've known that since the first description, right? Those first 3 cases were all women. And it's possible that differences in gender may explain why PH occurs. What is it about women that makes them get pulmonary hypertension more than men? Well, there's some obvious hormonal differences between women and men. Women tend to have more estrogen than men do, and so maybe that's where this, maybe that explains a lot of this. So aromatase is a gene which produces estrogen both in women, in postmenopausal women and in men. And we've actually found that different variants of this gene are associated with the risk of pulmonary hypertension. So there are a couple of genes that have been linked to causing pulmonary hypertension, and we found that people who have different variations of this one gene that's linked to estrogen increase the risk of pulmonary hypertension. Okay. Well, that's interesting. And what's also interesting is when we looked at the levels of estrogen tied to the variants of this gene, so 3 different flavors of the gene, we see that those people who got kind of 2 copies of the risk factor, this is the flavor of the gene that increases the risk of pulmonary hypertension, it also increases the level of estrogen. So there may be some tie here between levels of estrogen and pulmonary hypertension. Also very interesting was the study that was done in lungs from patients with pulmonary hypertension. And they actually found that this aromatase, this protein that produces estrogen, is actually found in the lung vessels of patients with pulmonary hypertension. And no one's ever shown this before. So surprisingly enough, in your lungs, there's an enzyme that's producing estrogen. And this may have a local effect and a local bad effect. Okay, so what next? So drugs that target estrogen have been around for decades, 20 or more years. And one of the oldest ones is called anastrozole or Arimidex. So this is an aromatase inhibitor. This is a drug which blocks that gene that I told you about before from producing estrogen. And this is a drug which has been used for decades to treat breast cancer. We know that estrogen is bad for breast cancer, and this drug decreases its production. This drug is generic. It costs like literally dollars or less a day. It's incredibly inexpensive. And it has reasonable side effects. Some joint pain, hot flashes. It can decrease bone density over long periods of time. There's a small risk of clots. But this is very well tolerated and taken by, literally thousands of women who've had breast cancer. Well, we thought, here's a drug that decreases estrogen levels, and it actually acts on this protein, which now we found in the lungs of patients with pulmonary hypertension. Maybe we should try it in patients with PAH. So this is another NIH-funded study that we're doing of anastrozole. It's a randomized study. So we're splitting patients, and we're giving them either sugar pills or the active drug. And we're giving them 1 milligram each day versus placebo and doing it for 12 weeks. And this is the first study of this medicine in PAH. So it's really preliminary to get a sense of side effects, how people tolerate the drug, and to see if there's any hint of efficacy here. We're going to look at echoes and walk tests to see if there's any signal that this may work. Before I leave this slide, we all know these drugs are expensive. This drug for 18 or 20 patients cost about $100 for all of the drug. So a very inexpensive alternative if we could show that it's effective. So the last study, and I think we're coming to the end of the talk here, is again another drug that's actually FDA approved, a drug called ranolazine. And this is a drug that's used for chest pain from traditional heart disease. So people who have coronary artery disease who get angina or chest pain, it's a drug that's used for them. So again, it's on the market, it's FDA approved. It also may improve right ventricular function, and as hopefully you know, it's the right ventricle that pumps to the lungs. And when something's wrong with the lungs, like pulmonary hypertension, it's the right ventricle that bears the brunt of it. And so there's some evidence that this drug may actually improve how the right ventricle pumps, how it uses energy, and maybe even how people walk around, how they function, and how long they live. So this is another study which will be starting soon, also funded by a foundation money. Okay. So bottom line is that there are multiple treatments for pulmonary hypertension. And I haven't spent really any time talking about that. And we certainly can speak more about it. But despite these available drugs, clearly this disease is not cured. We're doing new studies testing medications, which make sense, right? So these things should work, but we don't know if they do work until we test them in patients. And so we think looking at drugs which maybe other pharmaceutical companies or other bodies are not interested in studying may bear fruit. And I should emphasize, and this is the first time I'll talk about it, but we can talk about it more, the only reason that you all have therapies available for you are because people before you went into clinical trials, right? You all know that. The way the drugs are approved by the FDA is they need to show benefit in randomized clinical trials. So the only reason that whoever patient in this room is being treated with a drug are because other patients in 1998 or 2001 or 2005 were willing to go into a clinical trial, to go into research and be randomized to get that drug to market. And I think that's a point that's potentially lost on some people. Really the altruism here, which is responsible for having therapeutics available for this disease. So again, the reason that we have treatments are because we have patients who are willing to go into studies. Now we can ask questions and talk about anything from the talk or any other questions you might have.
I keep hearing about the way we want to cure. So how is cure defined?
Yeah, no, it's a great question. Cure is defined as eliminating the disease.
Yeah, I know that. But how do you know? How does one know?
Yeah, it's true. I think a disease is cured when really the parameters that are abnormal with the disease, the pulmonary artery pressures, the walk, and the survival are all 100% of what they should be, right? They're all normal. And unfortunately, we're not there yet. Now, a skeptic, I don't know if it's a cynic or a skeptic, could say, well, do we really need to cure it? We haven't cured diabetes, and yet we can keep people alive for 50 and 60 years with diabetes. So maybe we don't necessarily need a cure. Maybe we just need a really, really effective drug that makes it into a chronic disease that we can live with. And I have to say, when I started out in the late 90s, this was not a chronic disease. We did not have these therapies. At this point, it has evolved into a little more chronic disease that you can live with, right, with multiple medications. Like I said, I don't think we're at the level of diabetes and insulin, but that's, I think, a goal. If not a cure, at least that goal.
Do you have any data on Revatio?
I don't have specific studies to show you. It was obviously studied on its own as well as in combination with other therapies. And it looks like it's effective not only on its own, but even in combination with epoprostenol, for example. So there's been one study where it combined epoprostenol, the IV medicine, with sildenafil. And there was actually a survival benefit in that study. So it's actually a very potent combination. What's nice about sildenafil, it's now gone off patent. And so, there may be generics coming out, and so that may change how it's used as well.
What others have gone off patent? That's interesting.
Yeah, sildenafil has gone off patent, and I'm not totally sure about some of these details. And I think Bosentan would probably be the next one, and I'm not sure what time that is, but it's coming up. Other questions?
Given my background in corporate finance, it just seems as though what you need to find a cure is money.
It's necessary but not sufficient.
You need money and the skill sets to do the research.
Correct.
And you need patience.
Yeah.
And you need. It's really, this is a multidisciplinary effort. Without any one of these elements, you can't get it done. Right? You need the researchers, you need the clinicians, you need the patients willing to go into studies, you need the money to do the studies. Like I said, if any of those pieces are missing, nothing happens.
I'm just curious, you collect cells through biopsies, so from a lung that's still in your body.
No, it's for patients who are getting lung transplant.
Yeah, but I mean, like, if I have a lung biopsy,
It's true, although we try not to do lung biopsies in patients with pulmonary hypertension because we worry about the risk.
well, I had one
Yeah,
before they knew. So, I mean, let's personalize it.
That's okay.
At that point, could you have nobody knew, so they made slides and they shook the slides, but nobody did anything with the tissue. So that was wasted, right?
Right, and I mean, wasted is a strong way to put it, but you're right. It is a wasted opportunity, and it's also the reason. And if I know some patients come to Penn, my research coordinators will often descend on the poor patients during their visits because this is the opportunity to collect data, enroll people, even a blood draw. So a good example is we're trying to get blood on every patient in our practice. We've been doing this for the past 5 years since I've been there. The genes from your blood can live on essentially forever in a freezer. So 20 years from now, for whatever kind of pH you have, if someone has an idea about a certain protein or a certain drug or a certain cause, and they say, well, Dr. Kawa, do you have any scleroderma pH samples in your freezer? And if I have 50 patients from the past 20 years in my freezer, we can use those genetic samples to do those studies. So whether it's cells or genetic material, the stuff can last a very long time, and it's precious. Patients are rare. You know that. This is why the PHA exists. And in order to learn things, we need to have enough patients to do the studies. So you're right. Every time there's a clinical interaction or an opportunity to give a sample, that's think about that as the big picture. This is about the future and coming up with drugs which may help you, but may help people 30, 40 years from now who have the same condition.
My next question: how can I put this delicately? Cadaver tissue do you use? Like if I died, probably from lung problems, would donating my body to a center like yours be a benefit?
Yeah, so it's a good question, and we're all going to die, right? That's a reality of life, and so thinking about it, I don't know if it's morbid, but it's a reality. And often the tissues can be used, and even as much to look at the pathology to see how things have changed. What's amazing to us is there are some published reports of patients who've been on Flolan for 20 years, so IV propranolol, and they were doing great, and poor patient died from another reason. And when they looked at the lungs, you would think a patient on IV propranolol or Flolan for 20 years, that the lungs would look pretty good. And when we look at the lungs from that patient, there was disease everywhere. Wow. So even a patient who'd been on Flolan and was doing well on Flolan, I should say, there's still pretty dramatic disease there, which tells us that we're nowhere near a cure. And again, nowhere near even making this into a long-term chronic disease. So even for that reason, to see the changes over time would be important. Go ahead.
You mentioned the female sex as being a risk factor. You didn't mention other risk factors, such as post-splenectomy, lupus erythematosus, somebody like this guy here with high platelets. Mm-hmm. What are those solid causes of pulmonary hypertension?
So there are epidemiologic studies that have clearly associated splenectomy examples. So the spleen is an organ that lives on the left side of your abdomen, and it filters out your old blood cells. It's also a storage center for white blood cells, but really takes care of your red blood cells when they get old and crumbly and just aren't working anymore. And so there have been epidemiologic studies showing that getting a splenectomy, for whatever reason, car accident, surgery, is a risk factor for developing pulmonary hypertension. And we don't know why. We don't know why. It may be because the old crummy red blood cells that the spleen was filtering are now reaching the lungs and clogging up the works. That's one possibility. And then you talked about different kinds of diseases, high platelets, essential thrombocytosis. Again, there's a clear association. So it's clearly a risk factor for the disease, but again, we don't know why.
Well, the lupus anticoagulant seems like you ought to bleed, but actually you get thrombosis.
Yeah.
So that makes sense.
And that does make sense. And that's chronic thromboembolic disease, which is a little different form from pulmonary arterial hypertension. So that's chronic clots in the lungs which don't resolve. So you're right. That does make more sense. But some of these other risk factors are puzzling.
And then, you do this major surgery. And Duncan went out to San Diego for this surgery because they'd done more studies on this than the rest of the world combined. There's apparently he had clots in the periphery, more periphery of his lungs rather than proximal.
Yeah.
And tell us why that he is not a candidate and the people with the proximal, is that just because it's too difficult technically?
Yeah, so I'll back up a little bit. So there is one form of pulmonary hypertension which is curable, and that is chronic thromboembolic pulmonary hypertension. So this is a condition which, as I mentioned before, their clots get to the lungs and they don't resolve. Most people have clots in the lungs. We put them on blood thinners and the clots go away. A couple of % of these people, the clots don't. And those clots can cause pulmonary hypertension. So the treatment and the cure for this kind of pulmonary hypertension is an open heart surgery called a pulmonary thromboendarterectomy, where they open up the chest, put the heart on a bypass machine like they use for heart surgery, and basically open the vessels of the lungs, and they literally take out the inner lining of those vessels, so the abnormalities. And it's almost like a snake shedding their skin. They basically peel out that inner lining of the vessel. They sew the vessels back up, close the patient back up. It's a very big surgery, very complicated, and the reality is just what you said. They can take out clots that are in the larger arteries and even in kind of the medium size, but once things start to get the really small vessels, they just can't get out that far. And so whether you're a surgical candidate or not for this condition is based on where those clots are in the lungs.
Why do the majority of people with a pulmonary embolus, I'm sitting with a knee stent, get clots in their lungs and they dissolve, the vast majority, then why do some of them stay in their lungs and grow into the intima of the blood vessels and stick there so that you have to dissect them out? You just can't pull a clot out. Why is that?
Yeah, see, you're asking all the hardest questions and all the questions I have no answers to.
Do some more research.
I know. It's just I got to get back to work. There are systems in our body, the endogenous thrombolytic system. These are like the clot-busting drugs that they use for heart attacks. So we all have these compounds in our body, and we're all forming clots and breaking them down all the time. Just sitting here, you're forming little clots and dissolving them, minute by minute. In some people, for some reason, when these clots form, their endogenous thrombolytic system is not good enough to break down the clot. And there are different genetic risk factors for this. I think there's a fibrinogen risk factor. There are some risk factors for chronic thromboembolic disease. But again, the short answer is we just don't know why there's a small percentage of people, when they have a clot, can't break it down and have this abnormal response.
Those people more sedentary, for instance, you can increase your thrombolytic system by just exercising your legs. Yeah. It goes into your it's tissue plasma and you activate.
Yeah. So
why doesn't that work?
Generally not. It's not that the people are more sedentary than others. That does not seem to be a risk factor for chronic thromboembolic disease. It could be a risk factor for clots themselves. But, most of the people I've seen with chronic thromboembolic disease are some of the most active people I've taken care of. They're not necessarily just sitting around. So these are good questions. Go ahead.
First of all, I want to make an observation. Once when I was down to see Dr. Pulaski, Dr. Fishman walked in. I recognized him because I'd seen I don't know, just a picture, or I'd seen him at a conference or whatever it was. It was wonderful to see him in the flesh. It really was. Okay, now, next thing. You started out training to be an internist. I'm thinking now of the ZEBRA program that PHA is trying to promote. Mm-hmm. And the goal of that program is to get doctors to recognize pulmonary hypertension. In fact, what I call first responders of doctors. Sure. So how do we reach out to these doctors so they can recognize pulmonary hypertension.
And I
It
think
takes, it takes a specialist perhaps to recognize it, but
I think it's a good question. I think, in order to make a diagnosis, you need to think of it.
yes, and that's why you're thinking about a zebra rather than a horse.
That's right. So I think the way we get primary care doctors and internists to recognize this is just to have it in their differential. When a patient comes in who's short of breath, the usual differential is asthma or emphysema or congestive heart failure or coronary disease. And so pulmonary hypertension has to be just in that go-to list.
How do we, as patients and as a support group, get the physicians in this area to do that? Yes, Duncan.
I have a request into the Pulmonary Hypertension Association signed by my primary care physician, Alice McCormick, asking that they come and do a seminar for the medical community here in the Valley, Wilkes-Barre and Scranton, and be able to offer continuing education credits.
That's a great idea, and my recollection is that the first PHA on the road program 2 or 3 years ago was in Scranton. We could not get there, we were too far away, but it was in Scranton.
I got one answer to your question.
Yes.
The pulmonologist that failed to make this guy's diagnosis is no longer in Pennsylvania. That's good for Pennsylvania, that's bad for the state where he now practices.
Well, that is certainly true.
He moved to West by God, Virginia.
So I think, continuing education, having you as their patient is probably the best reminder of what pulmonary hypertension looks like, right? So
Well, I have my own internist, so she fully understands.
No, exactly. So, I think it's getting some of these other docs to some continuing education just to put it on their list of differential.
Whoa. So I need to figure out the process for doing that.
I think the PHA could probably be leveraged, having us come out and give talks to internists, getting a room of internists rather than a room of patients.
Yes. Excellent. And so maybe another on the road?
Sure.
That happens to be open for both patients and doctors?
Yeah, no, that's fine. That's fine. This is fine. Doctors, they'll come for food. They like, one thing doctors like, it's free grub. Oh, sorry, you had a question.
Do we have a pulmonologist and a cardiologist, or doesn't it matter?
I personally think, you mean for your pulmonary hypertension or locally or?
Well, I have two cardiologists.
Yeah, I'm not sure it matters. I think you need a good doctor, right? And good doctor, both pulmonologists and cardiologists can be good doctors. So that's what I would recommend more than one or the other. In terms of who takes care of these patients, probably in the country it's split. At Penn it tends to be more pulmonologists than cardiologists, but we have cardiologists that do it as well. We're all in the same practice. In terms of locally, like I said, when I want a local doctor, when I have a patient who lives in Scranton, for example, I want somebody who's good. It doesn't matter what their training is.
What about exercise? Like, what kind of cardiovascular exercises should we be doing?
Yeah, so exercise is interesting, and so we don't know if exercise is good for patients with pulmonary hypertension. 20 years ago, they did not let patients exercise, 20 or 30 years ago. They thought it was dangerous. This was in the era of no treatment. It was very different times. I recommend exercise for my patients, and there have been actually some trials showing that exercise may have some benefit. It's actual clinical benefit to the heart, to the lungs, to the muscles. But the way I do it, I like to be safe. I usually enroll my patients in a rehab program. It's a 12-week program, a couple times a week, where they monitor you while you're exercising. Duncan, I think you started that way, to kind of get you a safe prescription for exercise. When I...
He exercises.
Right, so they can also judge needs for oxygen. And really, it's a lot of common sense, listening to your body, right? If you're having chest pain, you're, very short of breath, that's not good, But like I said, I usually prescribe a rehab session, a rehab stint for all my patients before they go on exercise. And we're talking about aerobic exercises, right? We don't like people to weight lift. That's not the stuff that helps your heart and lungs. We're talking about walking. Not necessarily even on an incline, walking or biking, something aerobic.
Swimming.
Swimming's okay too. You know, physicians, I think, like all humans, can fall victim to pattern recognition. Pattern recognition, right? We look at things, we look at situations, and automatically things pop in our mind from our past experience. And I think that's just the way we're built. You know, you don't think about how to drive home from here. You get in your car and you just do it, because it's pattern recognition. You don't have to consciously, well, I'm going to turn right here and then make left here. And I think we need to change some of that. As you say, these patterns are based on shortness of breath and symptoms. It would be nice to break through that a little bit to get more cause, which is what you're talking about. But we don't have a single blood test, a certain genetic test, which tells you what the patient has in any of the diseases you named. And if that were the case, then you could say, well, I'm going to do this blood test and that will tell me what this is. And that doesn't exist. This continues to be a clinical diagnosis. It's recognition of the pattern, right? High pulmonary artery pressure, normal left side of the heart, otherwise normal lungs, no clots in terms of pulmonary arterial hypertension, and that's the diagnosis. But I think your point is well taken. We need to work towards that single blood test of the causal factor. When we find that, then we don't have to depend on the pattern recognition and the clinical judgment. This happens to me all the time. So all the time, I get echoes read outside of Penn by physicians who aren't necessarily thinking about pulmonary hypertension and the right side of the heart. And they'll run through the reading, and the left side looks fine. They'll say, okay, it looks okay. And they'll even write down sometimes normal right ventricle, when actually it's not normal. And that just happens to be the auto-populate on the form. So it is really important either to look at the echo yourself, or often I'll call the outside doctor and say, could you do me a favor, pull the echo and look at the RV while I'm on the phone and tell me how it looks. And so sometimes by doing that, you get a different read than what's on the piece of paper. The prevalence of the disease is, 20, 30, 40 per million, something like that. So again, not a common disease, but I have a decent number of patients who come from Scranton to see me. And it's a tough area because I think, we're probably equidistant. Again, we said New York City to Philadelphia, but there's probably a decent number of patients here. Like I said, I might, in my own small practice, I see a decent number of patients from Scranton. It's a problem up here like it is everywhere else. And I think because there's less maybe expertise focused in this area, maybe it seems, it's more pronounced,
Well, there's a short...